Let's continue with the next exciting session, oncology, I'm told. Can we have the panel moderator, Dr. Abrahamson? Panelists, we start with 3 talks, followed by 4 cases. I don't see anybody here. Come on up. Yeah, talks first. First talk by Anita, Neoplastic Diseases of the Retina in Adults. Anita Agarwal.
Good afternoon. I have no disclosures to disclose. The talk is on retinal neoplastic diseases in adults. This is a 67-year-old woman who has been treated for uveitis for the past 3 years with waxing and waning symptoms. Her vision in the right eye is 4:200, the left eye has hand motions, and the left eye shows significant narrowing of the retinal vessels, chororetinal scarring. And if you take a look at her wide field imaging, you can see these lesions that are sub-RPE in the superior part, and also an area of retinitis inferiorly. So these are all the various manifestations of primary intraocular lymphoma. The left eye has had some chororetinal scars where some of the lesions have resolved. And autofluorescence imaging is extremely useful in figuring out if this is primary intraocular lymphoma or uveitis. Autofluorescence shows variegated hyper and hypoautofluorescence, telling us that the RPE has been diseased. And an OCT through one of these sub-RPE lesions is absolutely pathognomonic of this condition. It matches the histopathology that you can see below. So this patient underwent an MRI of her head and was found to have lesions there, and LP was non-diagnostic. The critical diagnosis is based on vitrectomy and a retinal biopsy, not just a plain vitrectomy. This is another example of a patient who's unilateral, he's asymptomatic, just had cataracts, and he's 20-25. He has massive sub-RPE infiltrates, sparing his macula, but the autofluorescence imaging clearly shows us the macula is also involved. And an OCT confirms the location of the sub-RPE infiltrates. So this is a classic typical appearance of intraocular lymphoma. However, there are other manifestations of primary intraocular lymphoma that may be not as easy to diagnose. One of them is if they come in with just vitreous cells. These vitreous cells can be either diffusely distributed or they could be in clumps. So if you suspect this, get an autofluorescence imaging, even if the fundus looks normal, so that might give you a clue. It can mimic ARN or CMV retinitis with retinal hemorrhages and retinitis. And of course, if these lesions heal, they can leave chororetinal scars and can look like multifocal choroiditis. So the most important thing is to get an MRI of the head and a lumbar puncture, and a diagnostic vitrectomy with a retinal biopsy. A plain vitrectomy is, the yield is pretty low, especially if you don't have highly trained cytologists and pathologists. So if there is a retinal lesion, it's best to biopsy that. So in summary, it's important to have a high index of suspicion and be persistent. These are the various guidelines, and as I said, if there's an RPE involvement, you take a retinal biopsy, and recently PCR from ID88 is useful, and it's positive in nearly 90% of patients with primary intraocular lymphoma. This 68-year-old woman had loss of vision in the right eye for 2 weeks. She has an unilateral serous detachment. A fluorescein is typical of a serous detachment with pinpoint leakage. She has a history of AML but is in remission. The other eye is normal. And the oncologist tells me that her AML is in remission, her peripheral smear is devoid of any blast cells. And we looked at her skin, and we saw that she had these little lesions in her skin, and this was biopsied, and this is leukemia cutis. So she obviously has sequestered some leukemic cells in her skin, possibly also in her choriocapillaries and choroid, and that's why she developed a serous detachment. And they weren't going to do anything, so I gave her some steroids, and her serous detachment went away, her vision improved. Unfortunately, she died within 3 months. This was a young lady who was already in remission from HTLV1, adult HTLV1 retinitis, or lymphoma leukemia, and she presented with this retinitis and vitritis. Her vision's down to 20/70. You can see all the vitreous membranes. And at that time, we thought that she had CMV retinitis. So we did a vitreous tap and AC taps and TOF for various PCRs. And the oncology had an Ommaya reservoir. She had already had a bone marrow transplant, and she was in remission. Her Ommaya reservoir was tapped. Everything was negative. Her fluorescein clearly shows us that the vessels and the retina is involved. So she underwent all testing, and everything was negative. Her vitreous tap, AC tap, vitrectomy sample were all negative for every infectious organism. At that time, we could not do a PCR for HTLV1. And so I put her on valganciclovir initially before we had all the results. She didn't respond. She didn't respond to steroids. And she had a diagnostic vitrectomy, which came back as no cells of lymphoid origin. So she went off on a trip, and then comes back 5 weeks later, and her lesions have worsened. Her vision's down. So now I take her back and do a retinal biopsy at this time, and within a half an hour, or within 2 hours, the pathologist calls me and tells me she has HTLV1 leukemia lymphoma cells. So it's important to do a retinal biopsy. This is a 76-year-old gentleman who's asymptomatic, but has this lesion. The important finding is that the veins are dilated, and there are some superficial retinal hemorrhages. So he goes to multiple different institutions and and was followed by Steve Kim, my colleague at Vanderbilt. And over time, his lesions get a little bit bigger. A fluorescein angiogram is extremely useful. It tells you that the retinal vessels are completely occluded in this lesion. OCT shows retinal and subretinal involvement. He finally underwent a vitrectomy and a retinal biopsy, and he had anaplastic cells. And this was consistent with a tumor possibly from the lung. They could not determine where the site of origin was. So you can see how the lesion had progressed over time. This last one was a 67-year-old African-American woman who came in with 8 months of loss of vision or reduced vision. She was 20/50 in the side. The right eye was normal. She had the snowman-like thing hanging over her vitreous, and she had some vessels at the base. And I asked her what she does, and she's an avid gardener. And I thought she was quite unusual to see a toxocara granuloma in an older lady. An ultrasound showed that the mass was hyperechoic. There was some tractional detachment around it. And I sent off for some CBCs to look for eosinophils, and I didn't know how I could diagnose toxocara in her, and I said, come back in a few weeks. She doesn't come back for 6 months, and she's now 2,200. And the lesion's grown larger. So I take her in for a diagnostic vitrectomy and a biopsy. And I have a hard time cutting into the soft, spongy mass. And I realized finally that I won't get an answer with the pathology because I got a small little piece after really struggling for about 45 minutes. And then suddenly something clicked off, and I said, let me send the cassette for cytology. I was looking for eosinophils because I thought she had toxocara. The oncologist calls me, the cytologist calls me and tells me, oh, she has anaplastic cells from a liposarcoma. And she'd forgotten to mention to us that she had a perinephric sarcoma that was removed several years ago. Eventually, she underwent an enucleation, which confirmed the diagnosis. And so to summarize, you have to have a high index of suspicion. You've got to look for all modalities, both imaging and surgical, to finally make the diagnosis. And bottom line is retinal biopsy if you have a vitreoretinal lymphoma, and cytology from the cassette if you can't get an answer. Thank you.
The next presentation by Prithvi. We have here new life-saving treatments for uveal melanoma.
Thank you, Arun and committee, for allowing me to present. Here are my disclosures. They're also in the program. So some facts about uveal melanoma. It's the most common primary uveal malignancy you'll see in adults. It has an unacceptably high metastatic disease rate. And you all, as retina specialists, are often on the front line in diagnosing, managing, and supporting our patients with this disease. And what we'll talk about today are some new potentially life-saving treatments that are available in uveal melanoma. We'll talk about some of the current treatments for metastatic disease, new FDA approvals that have come across, and some maybe potentially new approaches for addressing this condition. So let's take a typical patient who comes in with a melanoma in their eye. You've made the diagnosis, and now we have to think about definitive eye treatment, which will include molecular prognostic testing via fine needle aspiration biopsy of the primary tumor. Recently, the Collaborative Ocular Oncology Group reported the prospective validation of both gene expression profiling and PRAME as biomarkers that will help us to decipher which patients are at low or high risk for developing metastasis. And our options for local tumor treatment enucleation or radiation have an incredibly high success rate at controlling the tumor within the eye. But unfortunately, metastatic disease is still the problem. Up to 50% of patients will develop metastases, predominantly in the liver, and survival with metastasis is dismally poor. So the story continues for our patient. They've been treated. They're being followed by an oncologist, getting scans, and approximately about 2 years after the treatment, in our high-risk patients, they may develop metastatic disease. So now active treatment has to be considered. Local resection, systemic chemotherapy, liver-directed therapies, or immunotherapy. So it sounds very appealing to take off-the-shelf directed therapies that are being used for metastatic cutaneous melanoma and treat our patients with metastatic uveal melanoma. Checkpoint inhibitors, kinase inhibitors, all have performed quite dismally in terms of long-term success, and survival at 1 year is less than a patient in uveal rather than non-uveal metastatic melanoma, because biologically and genetically and clinically, metastatic cutaneous melanoma is not the same disease as metastatic uveal melanoma. Luckily now, we have 2 new approved therapies for metastatic uveal melanoma. The first is a melphalan direct hepatic artery infusion system. So this is liver-directed treatment for unresectable hepatic metastases in uveal melanoma. So this system involves isolating the hepatic circulation from the systemic circulation, direct hepatic infusion of a very toxic chemotherapy agent, melphalan, and then cleaning that out by filtering the hepatic circulation before letting the blood go back into the system. The FOCUS trial reported an objective response rate of around 31% and disease control rate nearing 66%, which is quite good for this type of modality. But a third of patients do have a high risk of hematologic toxicity. This is a surgical system. This is not going to be done in your office. And we do know that this is used in liver-only disease. The second approval was for a drug called tependifusp. This is the first in cancer bispecific T-cell redirection therapy. By infusing these ImmTAC molecules, they attach themselves to specific GP100 signals on the metastatic melanoma cells, and then they recruit T cells to come in and then cause an immune response to the metastatic melanoma cells in the liver. A 3-year follow-up of a randomized clinical trial comparing tependifusp infusions to investigator choice, which is usually monotherapy immune checkpoint therapy, shows that at each time point, 1, 2, and 3 years, there is a benefit for overall survival in patients using this medication. The curves go down, but yet there's still a separation between the patients that are being treated or not, so this benefit is significant. This is an intravenous therapy. It has a high risk of neurotoxicity, and it's restricted to patients with a certain HLA type, the A0201, which is not a universal option for patients, but a common HLA type, and now it is first-line therapy. So if we think about, are there ways that we could, in the future, potentially prevent or reduce the risk of metastatic disease, we can talk about the concept of neoadjuvant chemotherapy to try to shrink tumors so that we can better address them surgically. So again, our patient with the melanoma, we give them a systemic neoadjuvant chemotherapy agent. The tumor within the eye gets smaller. You might then change your definitive treatment. Instead of enucleation, maybe it's radiation. Instead of a lot of radiation, maybe it's a little less. And once that tumor is treated, retreat them again with that same agent to try to eliminate micrometastatic disease and hopefully reduce the risk of metastasis. Darovasertib, a protein kinase C inhibitor, is one of these candidate molecules. It targets mutations in the GNAQ, GNA11 pathway that is active driver in uveal melanoma. This, in combination with other agents, has been used systemically for metastatic uveal melanoma, and it's shown good response. And interestingly, there were some patients that actually had untreated ocular melanomas treated for their metastatic disease, and their tumors got smaller within the eye. This has led to now a phase 2 global study of neoadjuvant darovasertib, taking patients who would be sent for enucleation or radiation therapy and treating them with this oral medication, and then following the response to see if it can save eyes or improve visual outcomes. And interim analysis of this phase 2 study shows that 61% of eyes that were destined for enucleation have so far been preserved, and about half the patients have seen a significant reduction in tumor volume. One of our patients who came in with a vision loss in the right eye, she has severe amblyopia in the left. In the right eye, we see this very large melanoma covering the visual axis, a height of 13 millimeters. This eye might be enucleated. On this twice-a-day oral medication, after 1 month, we can see the significant shrinking of the tumor, improvement of vision, and after 5 months, reduction of subretinal fluid even, and now we're planning radiation therapy. So as we take this path with our patients, it's important to be able to tell them that there are new approved therapies that may improve survival. We collaborate with our medical oncologists to get our patients into these important trials. And I think that it is safe to say that you can offer your patients hope, and you don't have to tell them there's nothing we can do for your melanoma if it goes outside of the eye. Thank you.
Next presentation by Jasmine Francis, Imaging Pearls to Distinguish Benign from Malignant Intraocular Tumors.
Thank you. Let's start here. Look at these 3 melanotic lesions. Which one do you think is benign or malignant, and how can we use imaging to figure that out? Well, let me show you how the first one here is a choroidal hemangioma. We can see that there is subretinal fluid on the autofluorescence. We can see that there is expansion but not compression of the choroid on OCT. And what's characteristic on the ultrasound is high reflectivity, which we may also call isointensity with the choroid. And then finally, the ICG is helpful here. You'll see early hyper, and then very late, at about 15 or 16 minutes, you'll see a very late washout. This middle one is a suprachoroidal hemorrhage. It's bland on the autofluorescence. It spares the choroid on ultrasound. Important here is the wide field OCT, which shows an intact choroid, and then this low reflective material sandwiched between the choroid and the sclera. And if you wait a month, it will dissipate over time. What about this last one here? This is a uveal melanoma. We can see a mixed pattern on the autofluorescence, a lot of subretinal fluid, the orange pigment also hyper-autofluoresces. The OCT shows a choroidal origin with subretinal fluid and the little punctate areas of orange pigment. The ultrasound there that I'm showing you is characteristic. It's dome-shaped, it's low reflectivity, it's got acoustic hollowing. It's spared in the ciliary body on UBN. That is important to establish. And just for the purposes of this talk, a fluorescein angiography showing a double circulation sign. What about these 3 more peripheral lesions? Let's start with this first one. This is peripheral exudative hemorrhagic chorioretinopathy, also known as eccentric disciform. It is largely hypofluorescent. On ultrasound, we can see that it's mainly in the retina and spares the choroid, again, not involving the ciliary body. And on ICG, we can see it's hypo, and there is a choroidal telangiectasia, which is almost polypoidal. This middle one is a chirpy. We can see that it's heavily pigmented on the color fundus imaging. It's densely hypo-autofluorescent. The ultrasound is flat. And on OCT, we see the characteristic thinning of the choroid and thinning of the overlying retina, as I'm showing you there as well. And this last one is a vortex vein varix. We can see that this is in the equatorial region. It's bland on autofluorescence and fluorescein angiography. On the ultrasound here, and the distended vessels on the OCT as it's draining into that vortex vein. And if you use Valsalva, you may be able to see enlargement of that. What about these multifocal amelanotic lesions? First one here is a sclerochoroidal calcification. Let's find out why. So it is hyper on autofluorescence. It's a bilateral process. The ultrasound shows high reflectivity with acoustic shadowing. That's very characteristic. And we can see this rocky or orthogonal appearance on the OCT with compression of the choriocapillaris. Middle one here are metastasis. The autofluorescence is very informative. It can show you the extent of the subretinal fluid. It can show you occult lesions that you might not otherwise see. The extensive subretinal fluid in this bilateral process. On ultrasound, it's got a mixed reflectivity. It can be multi-lobed, and you can see that again on the OCT. And then this final one is vitreoretinal lymphoma. It is also hyper-autofluorescent. We can see vitritis either at the slit lamp or with ultrasound. And the vitelliform material is sub-RPE. This has been described by Peachy et al. And on follow-up, following intravitreous methotrexate and rituximab, there's a nice response. What about these unifocal amelanotic lesions? What about the first one here? This is a granuloma. It's got rather indistinct borders. The patient complained of pain. There are cells in the vitreous. There's subretinal fluid. You can see that in many imaging modalities. And on the ICG, you can see these hypofluorescent punctate spots, which are not specific for this condition, but they do help. And this turned out to be a sarcoid granuloma, which responded very nicely to steroids. And this middle one here is a metastasis. This is a reminder that metastasis can be unifocal, unilateral. So again, extensive subretinal fluid, the undulating choroid, the mixed reflectivity on the ultrasound, and we can see that it does have vascularity on the fluorescein. This final one here is a choroidal osteoma, typically occurring in young females, predominantly in the posterior pole. It's highly reflective on the ultrasound, does have a shadow, and in the calcified portion of the tumor, you can see an intact RPE and inner retina, and these kind of lamellar areas within the expanded choroid. And just a reminder that these patients can get CNV. And then finally, these three juxtapapillary lesions. First one here is a retinoblastoma. These are glassy white. They can sometimes be calcific. On the OCT, I'm going to show you the OCT is important for all three of these lesions. You see a circumscribed lesion. It's sparing the nerve fiber layer and the and the outer retina, and you can see bowing of the outer nuclear layer. All of them can look sort of different from this, just an example of one. The middle one here is an astrocytic hematoma. These are also smooth, grayish-white, glistening. They can have intrinsic calcium, as you can see there on the ultrasound. And on the OCT, you can see that it's actually originating from the nerve fiber layer, which was distinct from the retinoblastoma that I showed you. And then this last one here is a focal scleral nodule. These are unifocal, creamy yellow, often near the optic nerve. They are hyperfluorescent, on autofluorescence. They are typically highly reflective, and there's the OCT showing that this is originating from the sclera. There is thinning of the choroid, and interestingly, there's rarely secondary retinal changes, and if you look closely, you can see the lamellar fibers of the sclera. Just a quick plug for cell-free DNA. This is a simple blood test. It can tell you the driver mutation of the disease that you're looking at. So in addition to imaging, this might nudge us closer to the diagnosis. And so by determining and detecting these gene mutations just with a simple blood test, it inched us closer to the diagnoses. So I've shown you all of these different diagnoses and the useful multimodal imaging in order to correctly diagnose them. Thank you.
Thank you. Now that you have learned about oncology, we are going to enter the second half of the program, which is a panel discussion led by Dr. Abrahamson. And we have learned panelists that include Lauren Dalvin from Mayo, Bill Harbour from Southwestern Texas, Ivana Kim from Harvard, and Carol Shields from Wills Eye Hospital. Dr. Abrahamson.
Thank you, Arun. Thank you for this opportunity. I do have a distinguished group, Dr. Dalvin, Dr. Harbour, Dr. Kim, and Dr. Shields, and really they're distinguished. This group has published more than 2,500 articles, and there are now more than 149,000 citations by these authors. So I think we can just sit down and say, job well done. Let's start talking about intraarterial chemotherapy for retinoblastoma. It's now used in all continents except Antarctica, in every United States center. More than 650 publications since our original one 18 years ago. And finally, in 2024, a prospective randomized trial was done comparing intraarterial chemotherapy to systemic chemotherapy. The intraarterial chemotherapy saved more eyes, saved more vision. It was faster and cheaper. These are 450 micron catheters passed from the femoral artery up to the internal carotid artery. And then when you're just above, you pull back, inject dye to make sure you're at the ophthalmic artery, inject. And for all of you in the room, that's an angiogram, not what you guys do. That's an angiogram. So I'd like to ask the panel members, and we'll start with Bill. Does your center do intraarterial chemotherapy?
Yes, quite a bit.
Okay. Carol?
Yes, several times a week.
Lauren?
Yes.
Arun?
Yes.
Okay. What percent of unilateral eyes? You know, in my fellowship, I was taught that all unilateral eyes should be enucleated. What percent of unilateral eyes do you presently enucleate a diagnosis? Bill?
Probably 10%.
10%. Carol?
Yeah, about 5%.
Yeah, 5%.
Arun?
I'm in Midwest, 50%. A little bit higher. I'm more conservative.
Okay. And we are presently at 5%. So this really is dramatic. We've gone in a very short period of time from enucleating almost all eyes to saving almost all eyes. How about bilateral eyes? Same question.
You know, it really has to do with the disease, not the laterality, so I'd say 5% again.
I would agree with Bill.
I find bilateral disease is usually detected at earlier stage, so I'm more around 2-3%.
So is this not remarkable? Think about when you all trained and how many eyes were taken out for retinoblastoma. We are all still removing eyes, and it's still a good treatment for the cancer, but it's actually becoming rare. Now, are we sacrificing patient survival by doing this? So the question is, of all the patients you've done, we've now passed 3,000 infusions. Of all the patients you've done, how many have died of metastatic disease? Or what percent?
0.
So of all the patients we've treated with IAC, one has died, but his eye had no tumor. His eye was enucleated with no tumor. He had metastatic disease, though.
0 deaths with
Okay.
IAC.
So we have some deaths. We have a very large practice, as you all know, but it's under 1%. So by leaving the eye in and attempting to treat it and save the eye and save some vision, we've not compromised survival. So let's switch and talk about small melanomas. Some call them nevomas, suspicious choroidal nevi, indeterminate lesions. They're generally defined as lesions that are thicker than a millimeter, thinner than 2.5 millimeters, a somewhat arbitrary designation. So I want to ask in the audience, how many of you have seen a pigmented fundus lesion that's over a millimeter and under 2.5 millimeters? Just raise a hand. So, I mean, it's virtually everybody, right? Yeah. And everyone on the panel has for sure. How many of you have seen a patient with a lesion like that that didn't grow who then developed metastasis? So I don't see any hands. Bill?
Yeah, grow or not grow, I won't comment on, but yes, I've seen small lesions metastasize.
Yeah. They do metastasize, maybe about 1% mortality reported overall.
It would be unusual, but it can happen.
This, of course, was part of the question asked by the COMS small tumor study, in which it was a, quote, observational study of tumors under 2.5 millimeters that weren't treated, that just were observed. It wasn't really a pure study because some of those did grow, some of those were treated. But actually, very few patients died, and in fact, of those patients, more of them died of heart disease. So if you were to see a lesion like that and you were really interested in patient survival, you'd send them to the cardiologist rather than all of us here on the panel. Arun has written about this and others, asking the question, in these small lesions, if you wait until they grow and progress, do you compromise survival? And their conclusion was no, you don't. By the way, this is somewhat important because some insurance companies are not allowing patients, as a result of the COMS study, to be treated with lesions under 2.5. So the next question is, that was before we had gene profiling, OCT, and some newer studies that have been published. So we'll now ask the panel, do you ever treat a melanoma under 2.5 millimeters? Bill?
Yes.
Absolutely, especially if it's diffuse, flat.
Yes, definitely.
Ivana?
Yes.
Okay. So there are a lot of lesions like this out there, and obviously very few are going to kill patients. What are the parameters, or what are the reasons? What guides you? What tells you that you should treat this rather thin, innocent-looking, but maybe not innocent lesion? Bill?
You know, at a first level, you know, I don't treat a lesion this small based on the clinical risk factors alone. I would need to see growth, and I'd need to see it in a relatively short period of time. If a patient was particularly concerned, we do biopsy these, and if I see not the GNAQ driver mutation, but if I see a prognostic mutation such as in BAP1, then we would, or if they had a class 2 gene expression profile, then we would treat them.
All right, Carol, you see these lesions. Which one do you think you ought to be intervening in? How do you decide?
We tend to use clinical risk factors, thickness over 2 millimeters, fluid on OCT, orange pigment on autofluorescence, vision loss, diameter greater than 5 millimeters, and ultrasound hollow. And if a patient has maybe 3 or 4 of those risk factors, we would lean towards treatment and talk to the patient about it.
I consider a few additional things. Growth is certainly one, and my favorite way to monitor small tumors is with EDI OCT. If I see definitive growth on an EDI OCT in a period of 6 months or less, that really pushes me toward treatment. I also consider patient age. If I have a 35-year-old patient, they have a long lifetime to potentially develop metastasis. So I'm going to be a little quicker to want to treat their lesion than if I have somebody who's 95. I'm not going to prolong that patient's overall survival, but I might decrease their quality of life with my treatment. And then diameter is the other thing that I consider. And Bill might have some comments based on the latest COOG data. I've had this 12 millimeter number in my head that I would really like to treat before we're wider than 12 millimeters because potentially they may have lower metastatic risk at a small size.
Ivana?
I think to summarize, I use the clinical risk factors to guide how closely I observe the patient, but I like to, for these lesions, observe them until there's documented growth, typically.
All right, now you've decided to treat them. How do you treat them? Bill?
If they're so close to the fovea that they're going to threaten vision, or if they're subfoveal, I'll usually start with PDT. And I have about half of those respond to PDT. If they're not directly threatening the vision, I go directly to plaque radiotherapy.
Yeah, so if the amount of growth is a little bit, we might even consider ARA nanoparticle therapy, Belsar. But if the amount of growth is more than 0.4 millimeters, like half a millimeter, we would probably go to plaque radiotherapy.
We have also enrolled patients in the belzuticap trial, so we'll see how the data shake out on that. For radiotherapy, I really prefer radiation to other laser therapies if I really believe something's a melanoma, because recurrence rate and overall treatment success is going to be much higher. I have both plaque and proton, so if I can edge out the fovea and the optic nerve with that hard stop that I get with proton radiation, I may choose to do that.
So if I've decided it's the melanoma, I typically do definitive therapy, which at our center is proton radiation. But these days, since the Belsar trial is an option, I would offer that as well.
Now we have so-called medium-sized melanomas, 2.5 to 10 millimeters in height, under 16 millimeters, again, the COMS designation. We know these are not good for you. And the question I have, is there any reason you wouldn't treat a patient with a medium-sized melanoma? I can think of a few things. Age of the patient, obviously concurrent significant medical problems, sometimes insurance, sometimes patients refuse treatment. My policy always was, for those few patients that you detect metastatic disease at the diagnosis of the ocular tumor, hold off on putting them through anything. They're not going to survive. They're not going to survive very long, and just deal with the metastatic disease. But as we published, and I know others here have had the same experience, about 40% of those that we didn't treat went on to have significant pain, sometimes requiring removal of the eye. So although treating the eye wasn't going to prolong survival, it probably would have been a better idea. So is there anything on GP, OCT, fluorescein, ICG that tells you that a medium-sized melanoma does not have to be treated?
Well, certainly not GEP. It wouldn't tell you whether or not to treat a melanoma. But of this list here, I would certainly not refuse treatment because of insurance. We would find a way, one way or the other, to take care of the patient. Concurrent medical problems, I would only enter in if there was if their life expectancy was pretty short, or the risk of complications of surgery were very, very high. Concurrent metastatic disease, when I was in training, was an absolute red line. You didn't bother treating the eye if they had concurrent metastatic disease. But now, as you heard earlier today, we have treatments that are increasingly effective. I routinely have patients that live 2 to 4 years with metastatic disease. So that's no longer a reason not to treat, in my opinion.
I would also add that there are several patients that we have that have 3.5 millimeter thick lesions, but there's overlying RPE atrophy or drusen and no sign of activity, no orange pigment, no fluid. We'd probably watch that.
Yeah, I have a small cohort of patients who are in their 90s or some of them over 100 years old, and I've had very frank conversations with them, and they don't want to go through surgery. I know that I'm probably not going to change their overall survival, and they are very happy with their decision, understanding the risk of metastasis, not to do anything about their tumors.
I would say the only reason on that list not to treat, in my experience, has been refusal, but the majority of those patients who initially refused do end up coming back with now a large melanoma, and many of them require enucleation.
Arun, are we out of time, or we have a minute?
You have one grace minute.
1 minute. Okay. Briefly, we're going to talk a little bit immune checkpoint inhibitors. You might want to get out your iPhone. There'll be some slides here that you don't have. They are the MABs. MAB refers to the receptor targets when they're expressed on the outside of cells. IBs are inside the cell, so they're smaller molecules. The substem of the MAB identifies the source of the antibody. For example, XIMAB, as in rituximab, a chimeric human mouse. Zumab, we all know, bevacizumab, humanized mouse. Mumab, fully humanized ipilimumab. The targeted therapy bullseye is the TU for rituximab if it's tumor, CI if it's circulatory system, and LI if it's the immune system. We've now got 4 groups: CTLA4, for which the Nobel Prize was given, PD-1, PD-L1, and now the LAG-3 inhibitors. So the last question is, what's the most serious ophthalmic complication you've seen of immune checkpoint inhibitors? Bill?
Death.
That's true.
Not common, but it can happen. Yeah,
Okay.
pituitary compromise, et cetera.
Ophthalmic. I mean, I get it that the eye dies, but... Carol?
Yeah, this was just about a month ago. We had a lady in the office. She couldn't open her lids. She had myasthenia gravis on checkpoint inhibitors. We sent her urgently to the emergency room.
Yeah, ophthalmic, I've seen irreversibly blinding retinal vasculitis.
I would say optic neuritis in a
And optic
monocular
neuritis.
patient.
Okay, thank you all.
Thank you.
Bill?